Welcome to this special episode of Diabetes Core Update, where we will discuss an update on the metabolic syndrome with a focus on triglycerides. I'm your host, Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special edition of Diabetes Core Update is sponsored by Amarin. Joining me today is Dr. Peter Toth. Dr. Toth is Director of Preventive Cardiology, CGH Medical Center, and an Adjunct Professor of Medicine at Johns Hopkins Medical School. He has authored or co-authored over 400 publications in the medical literature, is author-editor of numerous medical textbooks, including, just to name a few, Comprehensive Management of High-Risk Cardiovascular Patients, Current Controversies in Dyslipidemia Management, Comprehensive Cardiovascular Care in the Primary Care Setting, and Lipoproteins in Diabetes Mellitus. In addition, he is a past president of the American Society for Preventive Cardiology. Peter, welcome to our podcast.
Well, thank you, Neil. Glad to be here.
We're going to have two podcasts this year focused on the metabolic syndrome and triglycerides. In this first podcast, we're going to discuss the metabolic syndrome, what it is, why it's important, and then focus on some new data on triglyceride management. In the second part of this series, we'll be talking more specifically about what to do for our patients who are already on a statin and either not at goal or who have additional lipid risk factors that can be addressed. But let's just start with the basics. Peter, what is the metabolic syndrome and why should we care?
Well, the metabolic syndrome was defined about 23 years ago by the National Cholesterol Education Program. And it is comprised of 5 components: low HDL, high triglyceride, an abnormal glucose over 100, waist circumferences that are high for men and women, and elevated blood pressure. And this could be either an elevated systolic or a diastolic blood pressure, 130 over 85. You don't have to have both. It could just be one or the other.
And why is it an important thing for us to understand? And what is the underlying pathophysiology?
You know, metabolic syndrome has gone to a significant extent unrecognized. It still hasn't seeped into the system to an adequate degree. Metabolic syndrome represents insulin resistance, and insulin resistance paves the road not only to the development of type 2 diabetes, but it is also a very hazardous risk factor in and of itself for the development of atherosclerotic cardiovascular disease and all of its manifestations. Insulin resistance is highly injurious to the cardiovascular system because it's pro-inflammatory, it's prothrombotic, it's pro-oxidative, and it also induces endothelial cell dysfunction. The problem with having too much glucose that is not being taken up and oxidized by systemic tissues is that not only are you glycosylating hemoglobin, which gives rise to the well-known hemoglobin A1C that we measure and use as a biomarker for how well controlled a person with diabetes is, but now you're also glycosylating critical lipids, lipoproteins, proteins, enzymes. And this can lead to enzymopathies. And when you are forming glycosylated products in the vessel wall, you're also binding to receptors of advanced glycosylated end products, which triggers inflammation. It can activate nuclear transcription factors like nuclear factor kappa B, activator protein 1, and now inflammation, oxidation, prothrombotic events, abnormalities in histology are off to the races. And of course, this is a whole body phenomenon, and it impacts every system in our body. Your brain can become insulin resistant. And when your brain becomes insulin resistant, you can foul up appetite centers in the thalamus, the hypothalamus, the forebrain. You increase forebrain catecholamine secretion, leading to elevations in blood pressure, increases in heart rate, increased risk for arrhythmias. You notice, Neil, that things get very sloppy very quickly. And this is a very dangerous pathophysiologic state that basically eats you alive.
Peter, thank you for going over things in that detail, because I think most of us have heard of and recognize the existence of metabolic syndrome, but most of us have not, at least in primary care, much of the endocrinology world, really understood that root cause lying in insulin resistance that has all those downstream effects, which I love the word you used, that are hazardous, I think is the term you used, that really is so apt. It's clear that lifestyle interventions are foundational when we address metabolic syndrome, the appropriate diet, an appropriate amount of physical activity. It's also just as clear that often that's not sufficient. And we have pretty amazing medicines now and have become arguably pretty good at treating hypertension, elevated LDL, diabetes, prediabetes. And I understand that we don't reach the levels of control that we would like to, but we are aware of it. And now we even have good tools for obesity. Today, we're going to focus on triglycerides. And do you think that triglycerides are underappreciated compared to those other risk factors that we always think about? And if so, why do you think we underappreciate it?
Well, I think the issue of triglycerides is somewhat forgiving because although it is a very important component of metabolic syndrome and is a biomarker of insulin resistance in patients who were previously normal triglyceridemic, who then become hypertriglyceridemic, the role of triglycerides in atherogenesis is still being probed, and we are struggling to understand this. And so, and I think the other manner by which this is somewhat forgiving is that so many trials that have evaluated drugs that lower triglycerides have been negative. And this, of course, would be trials with drugs like fenofibrate and pemafibrate, very prominently the FIELD trial or the ACCORD trial or the PROMINENT trial. So, I get that part. But on the other hand, we do have to take triglycerides very seriously. And let me explain why. And this is why we're here today, to help inform. The role of triglycerides in atherogenesis is actually very interesting. Triglycerides can be broken down in the vessel wall by a variety of enzymes into pro-inflammatory molecules. This, of course, can lead to an increase in adhesion molecule expression by endothelium, a pro-inflammatory response, and the creation of an atherogenic nidus. But when you look at atherosclerotic plaque, unlike cholesterol, which accumulates in large amounts and is measurable and is reproducible because it's always there, you don't find much in the way of triglyceride. It's not a triglyceride dumping ground. And a lot of this has to do with the fact that your systemic tissues cannot catabolize cholesterol. But triglyceride is, in fact, a critical oxidizable substrate for all tissues, especially myocardium. And so you're not finding deposits of triglyceride because these tissues can catabolize the triglyceride, burn it as fuel. But there is strong evidence that the triglycerides, when they're broken down into fatty acid, can create pro-oxidative fatty acids that are typically long chain. The gut produces short chain pro-inflammatory fatty acids. It's a complicated soup, as is everything. Now, why should we really take triglycerides much more seriously now? Well, number one, we're finding that when you look at prospective longitudinal cohorts, even after you adjust for other lipids, triglycerides usually come out as an independent predictor for future cardiovascular events. All right, so that's good. But it turns out that it's probably because of remnant lipoprotein elevations. And what is a remnant lipoprotein? A remnant lipoprotein is a byproduct of VLDL metabolism. So your liver spits out VLDL, very large density lipoprotein, which is highly triglyceride enriched. This is broken down by lipoprotein lipase into progressively less enriched lipoproteins, which are going to be small VLDLs, then intermediate density lipoprotein, and then the end product of lipoprotein metabolism, which is LDL. The LDL is, for the most part, stripped of its triglyceride load and is very concentrated with cholesterol. Now, it turns out that small VLDLs, large VLDLs, and IDLs, based on data from the UK Biobank and based on multiple analyses from the Copenhagen Heart Study, Framingham, they're actually more atherogenic than LDL. And in the diabetic state, in the insulin-resistant state, in patients with metabolic syndrome, LDL is not necessarily the most populous of lipoproteins. The remnants can be. And a remnant can carry 3 to 4 times as much cholesterol per particle into an atherosclerotic plaque as an LDL particle. And they're pro-inflammatory. And the lipid in a remnant lipoprotein does not have to be modified, say, through an oxidative process to turn it into a scavengeable molecule by resident macrophages in the subendothelial space. So they are avidly scavenged by macrophages, and these are heavily enriched in triglyceride. And this is probably why triglycerides figure so prominently in the atherogenesis pathway. So our knowledge of this is evolving, but it's the remnant lipoprotein particle, and the triglycerides are a surrogate measure of those remnants in blood.
You describe it like a story well told. And what we measure here and what we have to work with, at least in our usual lipid panels, are triglycerides. Last year, we talked with Christy Ballantyne about that concept of residual risk. And for our listeners, that's that risk that remains after your traditional risk factors, including LDL, hypertension, blood glucose control, are addressed. And triglycerides, as you just said, in most studies, seem to fit in with residual risk as a component of that residual risk. And it sounds like it's through that pro-inflammatory cascade that you're mentioning. Is that understanding correct?
Yes, but let's face it, we don't even have the basics down. People talk about residual risk attributable to God knows what, and yet only 15 to 20% of high-risk patients get their LDL to less than 70. People are parked at an A1C of 8 for 2 to 2.5 years before any effort is made to titrate a medication to lower that A1C. Often a blood pressure of 150 over 90 is deemed pretty good and no additional medication is prescribed. So guideline-directed, risk-stratified targets are really very poorly achieved in clinical medicine, and it is catastrophic for the cardiovascular system. And I think until we get the basics covered, we really need to focus on these basics and help people understand how critical it is that A1C, hey guys, less than 7, LDL, less than 70 or less than 55, depending upon the risk stratification, blood pressure, less than 130 over 80. This is very simple. The problem is it is inadequately achieved in practice. And then people talk about inflammation. They talk about oxidation. They talk about, very esoteric issues that are simply not covered in practical everyday medicine.
Peter, I'm so glad that you brought up those numbers because it really is so important. So much of anything, and it doesn't matter whether it's shooting layups in basketball or taking care of cardiac risk in medicine, comes back to basics and foundational approaches. And absolutely agree with you that it's critically important in that everyday practice of medicine to address those basics. As we talk, if we were to focus on triglycerides,
Yeah.
and 100% need to address those foundational hypertension, blood sugar, and as I know you've talked about in other arenas, not just blood sugar, but the correct medicines to bring down blood sugar. We now live in a world of GLP-1s addressing cardiac risk, as well as SGLT2s with renal and heart failure risk. What are the interventions that are available to also address elevated triglycerides?
Yeah, so I would have to say that right now in the year 2024, the strongest evidence really lies with icosapent ethyl, or purified icosapentenoic acid. That's where the data are. We know that the fibrate trials have been negative. There was a lot of hope that based on post hoc subgroup analyses looking at patients with high triglyceride diabetes, low HDL, perhaps the fibrates would work. But the prominent trial was designed to evaluate that very issue. And it turned out to produce beautifully, perfectly superimposable Kaplan-Meier survival curves with absolutely no benefit whatsoever when these patients were treated with pemafibrate on top of a statin versus statin alone. However, icosapent ethyl clearly is highly beneficial, and based on hard clinical endpoints, it is also the only non-statin drug to have shown a mortality benefit when used in addition to a statin in high-risk patients whose triglycerides were 150 or higher. Now, do statins reduce triglyceride? Yes, they do. But obviously for patients with hypertriglyceridemia, metabolic syndrome, insulin resistance, if they have a genetic variant that leads to hypertriglyceridemia, let's say they overproduce ApoC3 or underproduce ApoC2, or they underexpress lipoprotein lipase, then really EPA is the only drug that's been shown to provide benefit.
Now, remind me, in the REDUCE IT trial, when you say people at elevated cardiac risk, what was the group that was included in that trial?
Well, they would be patients with established ASCVD or a diabetic patient with one or more additional risk factor covariates. They were all high risk, and everybody is on high dose, high potency statin, and then half the population is treated with placebo, the other half with 4 grams of the EPA. And, you know, the primary composite endpoint, the secondary composite endpoint, individual endpoints with MI, stroke, cardiovascular mortality, revascularization, remarkable reductions. Interestingly, the endpoint reductions were achieved independent of triglyceride reduction. And so people have been invoking lots of fancy explanations. But bottom line is you have to remember that EPA reduces remnants by about a third. And I'm quite sure that the reduction in the remnants contributed here.
That's a really good point. And can you go over for our listeners the difference between EPA and regular over-the-counter fish oil, and is there a difference between the two?
Yeah, well, EPA is the only fish oil that's been shown to provide benefit. We know from the JELIS trial done in Japan and also from REDUCE IT, both of which only used icosapentenoic acid, that they had somewhat similar endpoint reductions. Now, there are differences in the trial, but clearly you have 2 trials that show benefit. And with EPA DHA preparations, whether they're purified or over-the-counter, there's never been a positive trial showing benefit from a combination of EPA and DHA. And we've got at least 11 of those studies now, all of which have been remarkably negative. But the two EPA studies are in fact quite positive.
So that's interesting. When we talk about fish oil as a general category, not icosapent ethyl, there was a recent article in the BMJ that was a large cohort study. Do you mind going over those results?
Yeah, that included over 400,000 people from the UK Biobank that just looked at fish oil. So a lot of these people simply took over-the-counter fish oil. It was probably almost always EPA DHA. And they did find a modest signal for an increase in risk for stroke by about 5% and about a 13% increase in risk for atrial fibrillation. Now, it's very clear in Reduce It that stroke was reduced significantly.
Now, the group that you were referring to in the BMJ study was a group not at elevated risk, in that group at low risk.
But all the studies with fish oils in general, whether it's EPA by itself or with combination EPA DHA, for some reason do show a signal for atrial fibrillation. The signal in Reduce It was relatively modest. And I would say in the average patient, the benefits of the EPA outweigh the risks. It's not at all clear why some people develop atrial fibrillation, why there's a slight excess with EPA therapy or with fish oil in general. But it's there. As far as the signal for stroke that they found, it's possible that it's an excess of hemorrhagic stroke because fish oil does exert some antiplatelet effects and can increase bleeding risk very modestly, which is why surgeons like it stopped before any surgery because they don't like bleeding.
That makes sense. And if it's used in a large cohort, as you mentioned, that very large cohort of over 400,000 people who are not at elevated risk in that group, at low risk, it might be that the one, that this is just fish oil in general, and two, that in a low risk group, the benefit does not exceed the risk. And in the group with elevated cardiovascular risk, fish oil did seem to decrease MACE. That's why we target medicines in general to people who need them and not shotgun them to everyone. I know there are some new studies on icosapent ethyl over the last few months. Could you go over them for our listeners?
Well, there is a constant stream of new information coming out of Reduce It, and it's a gift that just appears to keep giving. I, for one, have been very impressed, not only with the primary results, but also with some of the subgroup analyses, which have been absolutely remarkable. There appeared to be particular benefit for patients who have stage 3 or worse chronic kidney disease, a GFR less than 60. They derived benefit that was greater in general than the groups that were 60 or above. Some of the other data that's come out that's very impressive is a 36 and 38% relative risk reduction of the primary and secondary endpoints for patients who sustained an acute coronary syndrome in the year before randomization. I mean, those are monster reductions on top of statin therapy. You know, a statin is going to give you about that after 5 years, but icosapent ethyl gave you another round of this on top of the statin. So with the icosapent ethyl and the statin, you're looking at a remarkable magnitude of risk reduction if you've had an ACS.
It's interesting.
That's something to ponder because, now that people are arguing that the EPA exerts so many anti-inflammatory effects, and probably it does. I mean, there are people, very smart people working on this issue. And there are many, many byproducts of EPA that exert a plethora of effects within human physiology. And if you have an ACS in the last year and you're getting disproportionate benefit from the drug, then it's a possibility that perhaps, in fact, it is cooling off hot plaque faster than the statin would have by itself.
Yeah, it is fascinating because that's not an area where I've heard a lot of emphasis, but boy, it's an important area because those people are quite elevated risk.
Yeah, very elevated.
We're coming to a close. If we were to leave our audience with a clear suggestion, when should we pay attention to triglycerides? Who should we think about treating that has high triglycerides? What's the take-home thought message after having gone through all the pathophysiology that makes us understand it better?
Well, in primary prevention, if someone has an elevation in triglyceride that is, let's say, in the 150 to 300 range, I would definitely strongly recommend lifestyle modification. If they've had normal triglycerides in the past, they've been gaining weight, and the triglycerides are inching up, then that is a clear marker of insulin resistance. And exercise and weight loss will definitely help them. There's no question it will help. Now, if they smoke, interestingly, it adds a reason to quit smoking because smoking potentiates insulin resistance. It's well known that cigarette smoke increases visceral adipocyte tumor necrosis factor alpha production, which induces insulin resistance. And this is why you could be thin as a rail, smoke 2 packs of cigarettes a day, and be a type 2 diabetic. If their triglycerides are over 500, then I'm very happy to initiate therapy with icosapent ethyl. If they're substantially higher and it's difficult to get them under 500, I will add fenofibrate. Despite the fact that the fenofibrate trials were negative, they were all done in secondary prevention. You have to get the triglycerides down in patients with more severe forms of hypertriglyceridemia in order to prevent pancreatitis. So that's practical. In secondary prevention, the REDUCE-IT trial clearly demonstrated that among patients with established ASCVD, or if they're diabetic and have additional risk features, icosapent ethyl at 4 grams a day, if their triglycerides are over 150, provides substantial incremental risk reduction over and above the statin therapy that they were on. This is a very big deal because it is the only drug to date that has been shown to provide a mortality benefit for lipid modification beyond statin therapy. And all of the other endpoints were substantially reduced. There is a slight increased risk for bleeding phenomena, for atrial fibrillation, but in these high-risk patients, it appears that the benefit outweighs the risks.
That's so helpful, Peter. Before we bring things to a close, do you have any last thoughts for our listeners?
Yes, I do. We need to take metabolic syndrome very, very seriously. Patients with metabolic syndrome, we see a clear rising gradient of risk as the number of components of metabolic syndrome develop in a person. And by risk, I mean not only risk for developing diabetes, but also for developing atherosclerotic cardiovascular disease and its manifestations such as MI, stroke, sudden death, need for revascularization. And remember that the development of insulin resistance predisposes to polyvascular disease. These are going to be patients who, for years before they were diabetic, were engines of atherogenesis because all of these risk factors have been operational for 5 to 10 years before they made the transition to diabetes. And so to wait until they become diabetic to treat their risk factor burden is a huge mistake because they're developing disease right before your eyes. So do a comprehensive inventory of their risk factors, stratify their risk, treat their lipids, their blood pressure, get them going on an exercise regimen, get them to quit smoking, and they will do better in the long run. But metabolic syndrome is very dangerous. It's underappreciated, underrecognized, and it is most certainly undertreated.
Dr. Peter Toth, thank you so much for your sage advice.
Thank you so much, Neil. Thanks for having me.
It's been a pleasure. And to our listeners, thank you for joining us on this first of a two-part series on an update on the metabolic syndrome with a focus on triglycerides, sponsored by Amarin. We look forward to you joining us for the second part of this series. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.